It's the start of a brand new week. Hello, good morning and welcome to News Desk. Coming up in the next 60 minutes, 2 children found dead at Kakpayili, a community in the Tamale metropolis of the northern region. We're live there for further details. Also in this bulletin, National Health Insurance Authority disburses over 587,000 Ghana cedis for free dialysis coverage in June. Stay for details. And later in the bulletin, imagine being diagnosed with diabetes at age 15 after your mother's leg was amputated due to the same condition. We'll bring you the story of Dorcas in our latest Hotline documentary titled NCDs, the silent epidemic.
Calling my mom to check up, so they've been telling me that because I'm the only child of my mother and then I'm the firstborn also, it can be heredity.
I'm Faustina Sava. Take a seat, you're my guest. On your screens now are visuals from Kakpayili, a community in the Tamale metropolis of the northern region where 2 children were found dead on Sunday. Residents suspect these children were murdered for ritual purposes as their decomposed bodies were abandoned in a vehicle behind the house of a spiritualist known as Malam Madaha. Well, Assemblyman for the area, Hafiz Adani, says the children had been missing since last Saturday. Joining us now is Northern Regional Correspondent Martina Bugri with further details. Martina, thank you for your time here on News Desk. I know you've been doing some digging. Share with us the chronology of events.
Now, what we know is that on the 22nd of June, the children went missing, and a search party was instituted to look for him. They had done that for some 2 days and could not find him. So the matter was officially reported to the police. And then on Saturday, just this Saturday, there were rumored that they suspected one man who they gave his name as Alhaji Rahman, but he's known around the house he lives in is known as Madahayil. So he was invited to the chief palace to be interrogated. But the people must have created a lot of tension. And so the police was called in to whisk him away to the police station where he was detained. But he was later released on bail. And we are told that he went on a radio station and a TV station to grant some interviews. And that triggered what happened yesterday. So yesterday, when that happened, the people massed up at his house. They tried to enter, and then that began the hostilities that took place, leading to the burning of the house. Now, the police had a very difficult time to stop the people. So what they did was they were able to, he has 2 houses in the neighborhood. They were able to secure one, evacuate the tenants who were in that house. But the one the wife and him live in was burnt. Now, what we are gathering this morning is that he's reported back to the police himself, and then the police are yet to begin questioning. Now, 2 people are in custody as we speak. His friend, who had come in with a rifle to rescue him, was also beaten and then handed over to the police. So he's been held for the possession of firearms. Another person is being held, I'm told, for inciting the people to come out and attack. So these two people are currently at the police station. My information is that there's my source within the police say one of the children was found on the front seat on the wheel, whilst the other one was at the back. I'm trying to get information from the hospital as to how the bodies came in. So that's what we have for now.
Now, currently, we're concerned about the state of these bodies that were found. Well, in your digging, did you find out if any part of these children was missing? The reason why probably residents suspect they were killed for ritual purposes?
That's what we are yet to find out from the hospital. My source says I should give him up to 30 minutes. They will get more information on how the bodies came in. But from the police source, they just say that the bodies were found decomposed. One was on the wheel and the front seat and holding the wheel, while the other one was at the back seat. That's what we have for now.
We know that the police has commenced investigations to determine the actual cause of the death of these children. But then what's the mood in the area this morning, Martina?
We still have police officers stationed in the community. I'm at the Chief Palace right now. We are trying to get permission to go into the community and begin to work. But I can see people gathering at the Chief Palace. Since we arrived, we've had people come in and then enter the Chief Palace. We are yet to understand what is happening. But people are going to work. The place looks calm. But that is not to say that everything is okay.
Thank you, Martina. We'll come back to you at midday for more updates on that. Now, let's do some other stories. Imagine being diagnosed with diabetes at age 15 after your mother's leg was amputated due to the same condition. Well, this is the reality Dorcas is struggling with to come to terms with. Now, her mother, Mercy Ogogbo, now faces the grim possibility of her second leg also being amputated, as it shows familiar signs of trouble. Now, they shared their story as part of our latest Hotline documentary, NCDs, The Silent Epidemic, co-produced by Emmanuel Jivenu and Seram Ablade Souza. Here's an excerpt.
When a daughter does not know how to interpret her emotions after being diagnosed with diabetes at age 15, the only sentiment she can dig up is hate.
I really felt bad and it hurts me a lot. It goes to some time I even regretted she was my mother, because I was like, if she's not my mother, I wouldn't have gotten that sickness.
A tough admission, though this sentiment has changed over time. From gaining a better understanding, the fear of her mother's fate befalling her lingers. Mercy Ogbojo lost her left leg in September 2022, 15 years after her diagnosis. The once busy trader is now confined to her home.
Sepio ninge store hulo province store sepio kan yo no yo apenya gbafu lopiole ichu enuku pingewe.
This life-altering procedure was the only way to keep her alive.
And ko egbanya se ja time munen ehiham kra enenokonya ne doctor binka ka puinanio la ema penya gba ka maham lo esane apona no kone mo no mape free ne ko ba sen no se na po no hu lololu o ka ke one pie lo hu enyinya gba.
Behind this show of strength is a deep-seated fear of the unknown. 2 years after the amputation, her right leg is showing signs she's familiar with. Mercy fears this could end her life.
When we talk about diabetes, we're looking at 3 key things. One is a chronic metabolic disorder. And why is the disorder? The disorder is that the person is either not making adequate insulin, or the person is producing the insulin, but the insulin is not functioning or working efficiently or effectively. So there's a problem with quantity, and there's also a problem with the quality. And then you can also have a combination of the two happening, where the insulin production is a problem and its function is also a problem. And once insulin is not working properly, then it means that the amount of sugar, what we call glucose in the blood, that the insulin has to help move into the cells of the body for the body to burn, stays in the blood. And then the sugar goes up. 1 month course of a newer anti-diabetic agent may be in the range of 400 to 600 Ghana cedi. So if the person has to be on antihypertensive as well, then you're looking at moving into the thousands.
She traces the disease to her father and uncle, a secret both men had kept from their children. Their silence may have been driven by the fear of stigma, denial, or maybe a desire to protect their loved ones from worry. This is a mistake Mercy has refused to make.
I've been following my mom to check up, so they've been telling me that because I'm the only child of my mother and then I'm the firstborn also, it can be heredity, so I should take good care of myself.
The non-modifiable risk factors may contribute between 30 to 40% of your diabetes risks, whilst the modifiable risk factors contribute almost 60 to 70%. So if you're able to handle those that you can do something about, then those that you cannot do, those you can do something about would overshadow what you cannot do anything about. Now, what are the things you cannot do anything about? That is the non-modifiable risk factors. The fact that you are black, you cannot do anything about your aging. The other thing you cannot do anything about is your genetic predisposition, that is your family history. So if diabetes runs through your family, then you stand a higher risk of also developing diabetes. Now, what are some of the modifiable things? What are some of the things we can do something about? Things like inactivity, weight gain, excessive alcohol intake, and then things like eating food that are so refined. They all put you at higher risk of developing type 2 diabetes.
Now let's speak to the CEO of the National Health Insurance Authority, Dr. Da Costa Boaje. Thank you for your time here on Newsdesk. I also have Professor Gordon Abeka Nkrumah, his Senior Lecturer, Public Administration and Health Service Management at the University of Ghana Business School. I'll start with you, Dr. Da Costa Boaje, because you are at the helm of affairs. How difficult is it when it comes to the number of patients we receive annually that are struggling with NCDs?
Thank you. Let me extend greetings to your listeners. I think from the NHIS perspective, we do fund diabetes and some of the NCDs. But I think what to me is the missing link is the approach that we have used over many years. So if you look at our healthcare architecture, it has actually been focusing on curative. And I think it's now time to introduce the preventive measures in such a way that it will contribute to addressing some of these NCDs. And I mean, looking at the video, it is really pathetic that preventable diseases are now a major cost burden on families and the nation. So I think we must actually look at addressing some of these NCDs from the basis when we introduce preventive healthcare as part of our healthcare architecture. So from the National Health Insurance, I think from next month or even this month, from July, we will be starting an annual health check model when blood sugar, blood pressure, and weight will actually be introduced as part of our benefit package. There is a committee that is chaired by Dr. Nafiba with all the experts on the table to see how we can finance the preventive aspect of this non-communicables as obviously we believe that is the next pandemic, and we must tackle it to reduce our healthcare cost burden.
How much is going to be going into this project?
In fact, it's now been costed, so I wouldn't really be able to tell you, because curative. But we believe that healthcare is not only curative care, preventive healthcare is also. So preventive healthcare should be part of our healthcare delivery system. So we are working on it, and the details will actually come out. All the experts are on the table, I can assure you with that.
Dr. Da Costa, stay with me, because I'll be coming back to you because of the new initiative that you put in place that has taken effect, which is helping the vulnerable in society with the cost of dialysis treatment. We'll get into that shortly, but let me bring in Professor Gordon Abeka Nkrumah, Senior Lecturer, Public Administration and Health Service Management at the University of Business School. Now, this NCDs is a silent epidemic, as Dr. Da Costa Aboagye has said, but then we're looking at preventive measures. What should we do?
Thank you very much, and good morning once again to your listeners. So I think this morning we had some conversation on this, and I think that the preventive measures are the way to go. And I remember saying on radio that oftentimes when we talk about NCDs, we're basically putting the burden on the health sector or the Ministry of Health and the NHIA, the one that Dr. Aboagye heads. But I think that's only part of the conversation. This is a national issue. It's not just an NHIA issue or Ministry of Health issue. And this morning, I decided to segment the people at risk into three. We have those who are adult and young people who currently have the disease. And then we have those in the middle who may be adult and children who have higher risk factors or predisposed. And then we have the much younger children who are in school. And for me, even those who are in school are the most important ones at the moment. We need to deal with that segment. And how do we deal with that? I would imagine that a two-pronged approach would be important, because NCDs are basically lifestyle and then nutrition. So for those who are in school, I would imagine we introducing NCD promotion and preventive measures in the school curriculum so that kids in school can be taught and they would understand the importance of making sure they stick to better lifestyles and better feeding. And for instance, those in school, the rich kids are the ones feeding on all these junks. Education at that level can help us. And for those who come from poor homes, and because of that, their nutrition is bad and their systems are becoming, adapting to being predisposed to NCDs. Things like the school feeding can be strengthened to ensure that we take care of those ones. And then for those at the middle who have a higher predisposition, we talked about feeding. So if it is feeding, access to vegetables in Ghana is not easy. And even when you have access, the quality is also questioned. I believe that the Ministry of Agri can handle this issue by ensuring there is, for instance, a module on the planting for food and jobs, which focuses on house gardening. And at that level, people can actually be encouraged to do household gardening so that they can have access to good quality vegetables and that which is affordable. And then those who already have the disease, that is where Dr. Da Costa comes in. And I think that his focus is something that should be applauded in terms of making sure that we are now even moving NHIA funds to focus on our prevention, what the former Director General used to call adult weighing. And so for me, I think if we move on these tangents, we can be dealing with the issues at all angles. And that would be my initial comments.
You made mention that NCDs it's probably a lifestyle disease. Now, in these economic times where people are struggling to afford 3 square meal, how do you manage your finances and ensure you're eating healthy?
Yes, so it's a lifestyle disease. Whatever it is the fact that regardless of the economic situation, we all eat. The issue is about what you eat and not whether we eat or we don't eat. We all eat. So whatever it is that we are eating, the content of it is important. Other things like exercise doesn't cost much. It's about going to work. Now, these days, I live on the university campus, and morning, evening, I find droves walking around. So sometimes we like to give excuses because of the economic condition, which I admit is hard, but we still eat anyway. And we're saying that we need to be a bit diligent and be careful about what we eat. Because if we don't do that, the cost of treating the disease, this morning you heard me in terms of what I was saying, in terms of, for instance, if you take hypertension right now, the direct cost per month on the system is about between 4.3 to about $5.7 million, okay, a month. And that's a lot. And this is just what the individual patients are spending, okay, before you come to what the government is paying. Remember, in Ghana, healthcare is heavily subsidized. So all that cost is not part of it. And so I think that if we can do it now, we save ourselves, okay, the catastrophe of having to pay this. For instance, if you take somebody with hypertension and chronic kidney disease, and of course, if you look at complications that comes with hypertension, chronic kidney disease is key. And it costs an average of around 4,832 Ghana cedis a month. That is directly on the individual. I'll ask you, how much is the average daily wage? And if you multiply it, how many in Ghana gets 4,800? And if you have to allocate that to treatment, it makes a lot of sense to say we sacrifice a bit in terms of being careful with what we eat and doing the exercise, which I think doesn't cost us anything. All that it costs is our time and a bit of walking.
I'm just thinking, if I'm having to choose between buying kinky, which costs 4 to 5 cedis, and then buying mangoes, which costs 10 cedis, what decision would I be forced to make as a result of my pocket? And that's where the concern is. Is there alternatives that we could look at?
All right, thank you very much. So once again, I say we have no excuse to defer the choices that we make today to rack up huge costs. I'll give you a simple example. I can afford to buy vegetables from the market. But this morning I was telling Kojo that if you come to my backyard, you see this dispensing bottle that is used in the offices, the big ones that they put on dispensers. I believe that Dr. Da Costa has one in front of his office. All I've done is that I've gone for some of them and I've just slashed the top. And I've just put soil in it and gone for chicken droppings. And I am planting lettuce. I am planting okra, okay? This is something that doesn't cost much, because I'm careful about the lettuce that I buy from the market, which I am not too sure how it is planted, the amount of chemicals they put on it. So yes, I hear what you are saying. Mangoes are expensive. But the point is that we need to encourage people that there are cheaper alternatives. There are people who can sit by the, what do you call it? That game, is it dummy? I don't know the English name for that one. What is? Draft. Yes, they call it draft. People can sit on draft for hours. Some of those hours can be invested into household gardening. And I think that these are life choices that we make. We are not going to get to any point where you would have access to everything you need. But in life, we make choices. It's trade-offs. And we need to encourage people that it's your own life. And it also brings cost to your family. It brings cost to the state. Think about somebody who has diabetes, and because of that, now they are incapacitated. It is not just you, it is your children and your children's children. And so if you are not careful, you're going to be having what I call intergenerational transmission of deprivation. Because you are poor and you cannot do much, your children are likely to be poor and your children's children are likely to be poor. And so we need to think about these things and let it inform the choices we make.
Thank you so much, Professor Gordon Abeka Nkrumah. Now, let me bring in Dr. Da Costa Boaje, because you are at the receiving end most often than not when the financial burden on the patients leads them to having some of these diseases. The NHIS then has to step in to help shoulder the cost. Now, the concern now is about educating the public. We have to do a lot of sensitization. What's your target audience in terms of the sensitization, and how soon will you be rolling it out?
Okay, thank you so much. So I think, you are right to say that we are the financier, but when it comes to the education, actually it boils on the Ghana Health Service and the other institutions, you see. So we need an all-society approach. You know, Prof made a very important point where the responsibility is not on the health service. The responsibility in terms of education and the choices we make is on all Ghanaians, and also it's also on the various institutions. Like, for example, we're doing what we call planting for food and jobs. You see, how can we make sure that we plant vegetables, we plant these fruits in such a way that it becomes cheaper for the population? You see, so how can the Ministry of Agri actually make sure that they reduce, obviously they focus on these vegetables and fruits? When you come to the other sectors, what is their contribution in reducing these NCDs? So, for example, I also know from the health sector point of view, there is something that we call One Health. The One Health approach actually talks about reducing the intake of, for example, meats. So how can we as a nation have what we call like meatless day, or maybe meatless Monday, for example? See, those are the lifestyle choices that Prof is talking about that's going to help. Because for NHI, we are the financier, but we don't really want to wait for people to get sick before we start to pay. We want to reduce our cost burden. So we are saying that our healthcare system cannot continue to be on curative. Preventive healthcare should be introduced. And there is also what we call the network of practice being championed by the Ghana Health Service. Under that, there is a model of education and some community engagement that is being piloted within for us to see the real cost, so that we will look at it from the NHIS point of view, whether it can't obviously be onboarded. But we don't just add stuff to our package. We really want to learn from it and look at the implications in terms of the sustainability of the scheme. So I think the whole society approach is what is going to help us. And I think we should take the advice of Prof and all the other stakeholders very serious in reducing these NCDs.
Stay with me, because I know that the National Health Insurance Authority disbursed over 587,000 Ghana cedis to healthcare providers for the treatment of chronic dialysis patients in June, making it the first month of its newly launched free dialysis coverage initiative. You know, here at Journeys, we've been championing this, and the program approved by Parliament as part of the NHIA's 2024 allocation formula reserves 4.4 million Ghana cedis to enhance access to dialysis treatment for vulnerable patients in Ghana. Now, these funds, they come from both the allocation formula and the NHIA's corporate social responsibility budget. Now, on your screen shortly would be the allocation for this June that we have. The NHIA fulfills payment for promise for dialysis patients. They sent 96,236 cedis to the Konfanoti Teaching Hospital. Now, for the Cape Coast Teaching Hospital, they sent 77,578 Ghana cedis. Now, for the Ifeanyi Regional Hospital, 92,308 Ghana cedis were sent to fulfill payment for dialysis patients among vulnerable groups. At the Whole Teaching Hospital, they received 83,470 Ghana cedis. At Tamale Teaching Hospital, they received 57,938 Ghana cedis. At Kolebu Teaching Hospital, they received 179,706 Ghana cedis. And we're joined because we still have Dr. Acosta Boaji with us. So let's get into the dynamics right now. For us here at Joy News, this is good news because we've been championing this cause. How does it make us feel? Excited, and I'm sure for the patients as well. Now, let's see how the service was able to spend all this money. Give us a breakdown.
Okay, thank you so much. So we actually, as you rightly said, last month we launched this initiative, and what we did was to make sure that facilities are also implementing this to the benefit package that we gave them. We noted that there were some challenges in terms of the patients actually still paying for it. So we introduced the next leg of what we call the refund to the patients if they are not able to obviously get that benefit. So for June, those patients who have actually paid for it, based on the numbers that were submitted to us that came to Confanoche and all the 6 facilities, will be refunded too. But because the NHIS, we cannot refund directly to the patients, we have to refund to the facilities for the facilities to reimburse the patients. So this is how it's going to work. If you are 18 and below or 60 and above, and you have paid for the June services, the 8 sessions, you have to produce your receipts to the various facilities for them to give you full refund. Because on Friday, I signed a check to the various facilities, and they will be receiving it today or tomorrow because of the weekend. So the facilities will coordinate or collaborate with the patients to do the refund for all the patients who have paid. And here I tell the facilities that please give back the monies to the patients. It is for them. For those who actually did not pay for it, the hospitals can actually keep it. This actually gives us the database for the real patients. And you can even see that the numbers that we came up initially, now it has actually reduced from the people who visited those facilities. So we are actually going to continue this and make sure that we follow it up, we monitor it, and make sure that the real patients are actually getting the full benefit of this program. So this is what I'll say for now.
We know that adult patients also, as part of your statement, you say they're going to be receiving some sort of subsidy for 2 dialysis sessions per month. Tell us more about that.
Okay, so thank you. So under the initial program, between the ages of 19 and 59, that depending on the facility that you are. So if you are from Confanoche, Efiang Panta, Cape Coast Teaching Hospital, then you'll be receiving 982 Ghana cedis, which is the cost of 2 dialysis, because the cost of one dialysis section is 491, as approved by the fees and charges from Parliament. So it's 491. So if you multiply the 2 sections, it's 982. But for Kolebu, because they already received support from the philanthropists, we are only funding 50% of the 2 sessions, which comes back to 491.
Thank you so much, Dr. Dacosta Boaji. He's CEO of the National Health Insurance Authority, for your time here on Newsdesk. Let's do some.
Welcome back to Business on Newsdesk. My name is Winston Taki, and now to our first business story. The Petroleum Commission says it is working to improve the gas export capabilities of the country. According to the Director of Local Content at the Petroleum Commission, Kweku Boateng, investment within the offshore sector have been modest, hence the need for a boost. He spoke to Joy Business at the 3rd Offshore Africa Energy Summit in Accra.
The summit was to explore measures to reform the fiscal regime in the oil and gas sector to safeguard it from the looming energy transitions and threat it poses to investment in the industry. Director of Local Content at the Petroleum Commission, Kweku Boatin, said, given the potential in the sector, there were concerns that if the country does not make an effort to attract investment, some of its hydrocarbon resources could be stranded.
For the past few years, you want to look at the West African sub-region, in terms of the investment to oil and gas sector, the investment has been very modest. It's not only in Ghana. When you look at even Nigeria, Equatorial Guinea, Congo, Senegal, in Mauritania, and other countries in sub-Saharan Africa, the investment has not been so encouraging. So it's not only a Ghana problem. However, there is a combination of many international factors, to some extent local factors. If you look at Ghana, for instance, for a period of about 2 or 3 years, we are having the issue on ATLOS, maritime boundary dispute with Côte d'Ivoire. We also try to look at the improve the gas export capability of the country. If you look at the planned investment in tenfold under the 10 enhancement program and other things that the companies are doing, we need to enhance our gas uptake potential by investing more in the midstream infrastructure, and I think that's what Ghana Gas is trying to do, to rather to start investing in the second train to increase the capacity of the gas processing plant and enhance the evacuation of gas to our downstream off-takers.
The summit was under the theme Africa and the New World Energy Order.
Now, away from that, the British Council is calling for the addition of entrepreneurship in the curriculum of all second cycle institutions in Ghana. According to a report by the World Bank, over 110,000 students graduate each year from tertiary institutions. Deputy Director of Programs and Partnership at the British Council, Richard Kwesi Shiangbo, believes encouraging startups and entrepreneurships will reduce the country's unemployment rate. He spoke at the UK Alumni Dialogues event, a networking session to commemorate British Council's 80 years of existence in Ghana.
Over the past 80 years, the British Council Ghana has achieved numerous milestones, including investment in developing Ghana's human capital through scholarship initiatives and support for entrepreneurial efforts of the youth. The socio-economic impact cannot be overstated, as the Council has held various support programs in the creative economy, the technical and vocational space, and special support for community and entrepreneurial projects. Speaking to Joy Business at the Alumni Dialogues event, Director of Programs and Partnerships at the British Council, Richard Kwesi Shiangbo, called for a massive entrepreneurship drive in tertiary institutions to create entrepreneurs to reduce the rate of unemployment in the country.
Our educational system should not always churn out graduates to come and be looking for jobs. At least they must be able to inculcate curriculums, that international curriculum, that tells the student, or that tells the let's say the potential what a graduate, that when you are coming out from school, there are pools of what unemployed people what in the system already. You must make a difference. So entrepreneurship puts you ahead of your colleagues who do not even have any skills in entrepreneurship. So entrepreneurship is very key. So that's why we are calling for all tertiary institutions to inculcate entrepreneurship curriculum in their schools.
He details the impact of the British Council in Ghana in the past 80 years.
So we are having impact in the Ghanaian youth and the Ghanaian economy. When you go to most of the industry players, for instance, we have what they call the UK Ghana Chamber of Commerce. When you go to this institution or these industry players, you have a lot of UK alumni in there. They are contributing their quota, they are learning skills. That means the student-centered approach, skills of learning. So in Ghana, for instance, there's an issue for us to shift from the teacher-centered approach, that to the pedagogy of learning, to more a student-centered approach that can develop the cognitive skills, the critical thinking, and the entrepreneurial skills of these our young ones. And this research truly shows you that our alumni are doing great jobs in their society.
The theme of the celebration is 80 years of building connections, understanding and trust, turning legacies and lessons into innovation and impact.
That'll be all for business. My name is Winston Taki. We have more news for you after this break. Stay tuned.
Thanks for staying with us. Now, Diaponko and 2 other communities in the Kakpayili North districts are wrestling in a daily battle for access to clean and quality water for the upkeep of their households. In our Thirsty Community series today, Clinton Yibwa uncovers the stagnant ponds they drink from, risking their health in an attempt to satisfy their thirst. There's more in this report.
Is one of the communities in the Kakpayili North district battling with access to quality drinking water. For the longest time that this community has existed, this has been the major supply of water to many households, and the challenge that comes with drinking from this pond is an eyesore. Traveling to the isolated areas of Kakpayili North district is a fraught adventure of setbacks. But none of these challenges is as blunt and plain as the struggle for access to safe drinking water faced by Diaponko and its next door villages. Diaponko, Ejajibiakra, and Ejakunti are clusters of communities in the district where residents trek miles to fetch from the Apemesu Pond. The Apemesu Pond is a natural still water with the size of a normal backyard pond sheltered by weeds and aquatic plants. Residents make their way to the pond daily to survive. With plastic containers, including the popular Kofo gallon and calabashes in hand, they dip into the murky waters. They fetch enough, disregarding the noticeable particles in it, and make their way to their homes or quench their thirst on the spot, just like this gentleman. However, the old and winding pathways leading to the pond are worn and muddy. The pond, now turned stagnant and filled with debris of all kinds, gets muddy every time. Eja Kakari vividly recounts when the Apemesu Pond was clear and reliable water source. There was always a calabash to drink with. Later, they created this path, allowing for mud and dust to get into the pond. Now, even animals drink from it. This is not all that there is to the safe water crisis. The situation gets worse as the pond is shared with livestock. The goats, sheep, and dogs we see here quench their thirst from the same water source. Stagnant water can become a breeding ground for harmful microorganisms, but sharing drinking water source with animals is a risk of heart diseases transmission, and these deprived residents are very much unaware of such risk. Seidu Iliasu is the unit committee treasurer. Our issues are many. Imagine all the bacteria from animals and having to share a drink space with them. The crisis gets more fascinating. The farming village with 2 traditional boreholes is not better off. The borehole offer little relief as residents recount how one is often dry and dispensing water tainted with oily substances. The first one they drilled spoils frequently, so they drilled a new one, which turns oily in few days. Meanwhile, the other faintly functioning borehole frequently breaks down due to overdependence from the growing population of the villages. This compels a section of residents to go back to depending on the pond as their only water source.
One of the pipes is spoiled, and we don't even have money to repair. Look at our numbers. Not all of us can use the pipe water. The multifaceted canker has a share for school-going children, as they are made to wake up early to join long queues to be able to fetch from the faintly working borehole. The scarcity of quality water devastates education progress. Jalilu, a student of JHS1, describes the ordeal of fetching water every morning. It gets to a time all the two can spoil, and we will have to struggle to get water. We have to wait in long queues to get some. The plight of these rural enclaves are seemingly not noticed by authorities. Swale Nanadodo is aggrieved by the neglect of Driaponko and its adjoining communities as he speaks about their efforts and the support they receive from the government. We are a lively people. Trade and food are bountiful here, and we vote too, but it appears we are not part of the country. Meanwhile, Seidu Ilyasu, the unit committee treasurer, joins calls to provide the struggling communities with safe drinking water. The There is nothing here. Even the roads are not good. We are crying for help.
Well, that's it for NewsX. For more news, please log on to myjoyonline.com. My name is Faustina Safo. Good morning.